Hi, I'm Blair Graham from the Western Michigan Homer Stryker School of Medicine, here on behalf of my team to discuss delayed ANCA positivity, a challenging case of multisystem EGPA. Vasculitides are notoriously difficult to diagnose and often are not diagnosed until the disease process is advanced. Symptoms can be isolated to one system or present as a smattering of symptoms that are evaluated individually. Testing patients for anti-neutrophil cytoplasmic antibodies reactivity, or ANCA, is a common practice, though in reality only an estimated 30 to 60% of patients with eosinophilic granulomatosis with polyangiitis, or EGPA, are ANCA positive, which can lead to a further delay in diagnosis. We report a case of EGPA with multisystem involvement in a patient with an initially negative ANCA. A 56-year-old Caucasian female with a past medical history of hypertension, epilepsy, asthma versus chronic obstructive pulmonary disease, chronic hepatitis C secondary to distant history of intravenous drug use, nasal polyps, and generalized anxiety disorder, presented to the emergency department and was admitted to the hospital for a presumed urinary tract infection with acute kidney injury and sepsis with shortness of breath. Her renal function did not improve over the hospital stay. Her urine cultures and ANCA were negative, and she was treated with ceftriaxone, then cephalexin, and azithromycin for presumed pneumonia. She was discharged with outpatient nephrology follow-up, where it was recommended that she undergo a renal biopsy due to increasing hematuria and proteinuria. She declined a biopsy at that time due to cost concerns. She presented to the ED again 1 month later with a 15-pound weight loss, arthralgias, generalized weakness, diarrhea, nausea, hemoptysis, elevated troponins, and decreased urine output. Rheumatology was consulted and recommended an outpatient renal biopsy with additional laboratory workup, including repeat ANCA. She was discharged with high-dose steroids, and her hydralazine was discontinued due to concern for possible drug-induced lupus, though she was not able to pick up her steroid prescription after discharge. Her repeat ANCA came back positive after discharge, and she was called urgently by her nephrologist to return to the hospital for IV steroids and inpatient renal biopsy. At this point, she was anemic requiring transfusion, in hypertensive urgency, had a severe acute kidney injury, had new oxygen requirements of 3 liters nasal cannula, and had likely diffuse alveolar hemorrhage on chest CT that can be seen on this slide, although this could not be confirmed as a bronchoalveolar lavage was unable to be done. She underwent a renal biopsy, was started on high-dose IV steroids, and received an initial dose of cyclophosphamide. She was transitioned to oral steroids on a long taper and was discharged on home oxygen with close rheumatology, nephrology, and pulmonology follow-up. Renal biopsy results returned after discharge and supported a diagnosis of EGPA. She improved on her treatment regimen and was able to be weaned off of her home oxygen after a few months. Her renal function improved significantly, though did not return to her baseline. Repeat chest CT showed resolution of the previously noted inflammation versus diffuse alveolar hemorrhage. ANCA positivity is a hallmark of EGPA and other ANCA-associated vasculitides. Unfortunately, despite a multi-organ presentation, some cases of EGPA initially present with a negative ANCA. This often falsely reassures the clinician of disease absence. Awareness of this discrepancy allows the clinician to keep a high index of suspicion when multiple pieces of data support a diagnosis of EGPA despite a negative ANCA. To overcome these situations, early pursuit of a tissue diagnosis allows for prompt therapy and potential prevention of devastating morbidity and mortality. The take-home points for this case are that negative ANCA is not sufficient to rule out a diagnosis of EGPA and to pursue early tissue biopsy when possible. These are our references, and we appreciate you taking the time to watch our presentation. Thank you.